everyone. My name is Justina Kopek, and I am a healthcare technology consultant at MIPs Technology, and I also have Vida Giacomovic with me, who is a healthcare technology engineer. I want to thank everyone for taking the time to join today's webinar. For today, we will be discussing MACRA, the new payment reform, and how to avoid penalties. In just a second, I'll hand it over to my colleague Vida, and she will take over the webinar.
Thank you, Justina. Hi, everyone. Thanks again for joining. So as Justina mentioned, we will be discussing MACRA today. So let's go ahead and jump into what is MACRA. Okay, so MACRA stands for Medicare Access and Chip Reauthorization Act of 2015. It repeals the flawed sustainable growth rate formula with a value and replaces it with a value-based care. So what that means is that by 2018, 90% of your fee-for-service payments will be tied to the value and quality that you provide to patients. It is expected that other payers will adopt similar models in the coming years. So we'll discuss what MACRA is and how you can meet it. So MACRA has two tracks. The first track is your MIPS track, which stands for Merit-Based Incentive Payment System. And this particular track combines the existing meaningful use, PQRS, and value-based modifier programs into one. Track 2 is the advanced APM track, such as Medicare Shared Savings Program or Comprehensive Primary Care Plus initiative, if you're a primary care provider, offers slightly different incentives for physicians, and we'll discuss those later on. So the most important thing to take away from this slide is that MACRA has two ways that you can meet it. The first one is your MIPS. The second one is your advanced APM pathway. Eligible clinicians must choose either one of these to start meeting MACRA in 2017. So 2017, we're going to go over the whole timeline, but that's going to be your first performance year for MACRA, and you must have one of these in place and perform one of these, either the MIPS or the advanced APM, starting January of 2017. So one important thing to also know is that MACRA builds further on the Medicare EHR incentive programs and requires a certified EHR technology. So please make a note of the word certified. If you are a micro physician at the moment, you probably have a certified EHR technology unless you haven't upgraded in a really long time, but we typically try to take care of that. So if you have questions, let us know and we can confirm whether your EHR is certified. Okay, so at this time we'd like to offer a poll question. So the question is, are you utilizing electronic health records? I'm going to open the poll and leave it open for just a few seconds until we get all responses. Okay, I'm going to close the poll. So it looks like 56% of you said that you are utilizing electronic health records, so about half of everyone who voted. 22% are not, and 22% are, but they feel like they're not really utilizing them to the fullest potential. So for those 22% that feel like they're not utilizing them to the fullest potential, ask yourselves whether it's a matter of, are you happy with the electronic health record system that you're using? Do you feel like you need more training? What is the reason that you're not utilizing it to its fullest potential? And then get in touch with us and we can see if we can guide you into the right direction. For the 22% that are not using an electronic health record, this is the #1 requirement for you to be compliant with MACRA. So make sure that you speak with us to guide you in a direction of choosing an electronic health record. Without that, you will be penalized. Vida's going to give you more information on that in just a little bit, and 56% of you are, so that's great. We're happy that the majority are using the electronic health records. So let's hand it back over to Vida. Okay, so let's move on to the next slide. Who is eligible, or really what we should be asking ourselves is who will be affected by MACRA. MACRA penalties and or rewards will affect any eligible Medicare Part B clinician. There are some exceptions, and we'll review those a little bit later on, but the important thing to notice is that you're a physician assistant or a clinical nurse specialist and you were previously excluded from meaningful use. That is no longer the case. MACRA includes almost any type of a physician, certainly everyone listed here. On top of that, in the third year of the program, there's a statute that they can add additional types of physicians to this list. So if you're a physician a physician's assistant, a nurse practitioner, a clinical nurse specialist, a certified registered nurse anesthetic, or a certified nurse midwife that sees or that bills Medicare Part B for fee-for-service, you are supposed to do MACRA. Okay, now let's look at the timeline. When does MACRA start? It starts now. The first performance year for MACRA is 2017, which is only 3 months away. We have to start it in January of 2017. Now, there are two types of financial impacts for clinicians of MACRA. So let's take a look at the first part of this timeline, the physician fee. So we can see that from 2015 until 2019, physician fee schedule payments will inflate by 0.5% annually. The physician fee schedule will freeze from 2020 through 2025, and then start back up in 2026 with eligible clinicians under the MIPS track being able to get a 0.25% annual fee schedule increase, and those that decide to do the advanced APM track are eligible for a 0.75% increase annually. So here you kind of have to ask yourself, you know, are you going to be eligible for a MIPS or for an advanced APM track? And that's how these are going to affect your physician fee schedule. Now, on top of the inflationary adjustments, let's focus on the MIPS timeline, which is that second portion of the timeline here. It comes into effect in, as I mentioned, January of 2017, with it being the first performance year. So the payment adjustments work the same way that they did for meaningful use and for PQRS, and will display 2 years after the first performance year. So if the performance year is 2017, then your awards or penalties that you get for that performance year won't reflect until 2019. And so for 2018, they will reflect in 2020, for 2019 in 2021, and so on. So what that means is that for each of these performance years, CMS will set up a baseline or a performance threshold, and provider earning those points will receive a 0% adjustment. Each incremental point above the threshold will result in more incentives, whereas if you fall below the threshold, there's going to be a proportional penalty. So, for example, let's take a look again at 2017. You will see a 4%. So if I look at 2017 performance year, 2 years later, your incentives or your penalties will reflect, which means depending on how you do in 2017, you will see a positive 4% payment adjustment on each Medicare Part B claim in 2019. If you are below the baseline or don't participate at all in 2017, you will see a negative 4% reduction in Medicare Part B claims in 2019. So this 4% that increases to 5 and then to 7 and eventually caps out at 9% in the performance year 2020. So that means that a physician that does not participate or falls below the threshold in the year 2020 will see a negative 9% adjustment on Medicare Part B claims in 2022. So on the contrary, a clinician that does participate or does well will see a positive adjustment. So that's your MIPS timeline. Now let's look at the providers are eligible for the APMs. The APMs timeline, that also starts out in 2017. Now the advanced APMs also involve third-party Medicare payments such as United Health HMO, for example. So the reimbursement amounts and the potential losses can vary. In examples of comprehensive primary care initiatives, for example, your rewards are your potential losses. So they give you money up front that if you then don't meet certain thresholds or certain criteria, they can take away. So you're essentially kind of at a place you're started at if you don't do well. You have to see whether or not you're eligible for an advanced APM, and we'll get into that a little bit later on as well. Okay, so let's look at your consequences. Let's summarize the slide from before. In summary, MIPS could result in an incentive payments reaching up to 37% of your Medicare Part B payments by the 4th year of the program. So let's take a look and see how. So let's say that you don't participate in any of the years from 2017 through 2020. That means, and that you typically bill, for example, $1 million of your Medicare Part B annually. So if you don't participate from 2017 through 2020 at all for those 4 years, and you bill $1 million in Medicare Part B annually, then keeping the previously discussed 4, 5, 7, and 9% negative adjustments in mind, your practice will end up losing $250,000 over the span of the 4 years of the program alone. What happens if you do participate? Then that loss could become your incentive. So now with incentives, math gets a little bit trickier, but it works to your advantage. So for example, MIPS is a neutral budget program. What that means is that your penalty is another provider's incentive gain, and vice versa. So to keep this program at a budget, or at a neutral budget, Medicare will set up a budget neutrality factor for each year so that the total MIPS incentive pool in dollars is equal to the total MIPS penalties assessed. Essentially, what you lose is what the other provider gains, and the other way around. So this neutrality factor that Medicare is going to set up for each year could be anywhere from 1 to 3 and will tap out at 3. So that means that if the neutrality factor is 3, then in the performance year 2020, where your potential incentive is 9%, you could earn up to 27% in incentive payments. So you end up multiplying your potential incentive by 3, and that's 27% that you could have as your incentive payment. Now, on top of this, Medicare also offers a 10% bonus for exceptional performance that fall within the top 30%. So that means that on top of this 27 that you could be getting if you perform really well in the year 2020, and if the neutrality factor is 3, then on top of this 27%, you could have another 10% if you do exceptionally well and you fall within 30% of the providers that participate. You could have a 37% incentive on your Medicare Part B for a single year alone. So if you bill $1 million in Medicare Part B annually, then for the year 2020 alone, your incentive could be as high as $370,000. If you bill, let's say, $500,000 in Part B annually, your incentive would be $185,000. And then for smaller practices that, let's say, bill $11,000 in Part B Medicare payments, your incentive would be $4,070. That's almost half just for a single program year. So it's a large amount of money. It's a large amount of money to lose, as you see reflected on this slide. For, depending on, on the amount that you make. It's an even larger percentage to gain because now the neutrality factor comes into effect, and also the 10% bonus that you may get if you do really well. So you have big losses, even bigger gains if you do well. Let's do another poll question. And the poll question, is participation even worth it? Okay, so I'm going to go ahead and close the poll. Actually, I think it looks like we did close it, but 58% of you voted, and 86% of you said that participation is worth it. So we're glad that you're seriously considering these numbers and realizing how imperative it is for you to understand MACRA and participate in it. 0% of you said that, 0% of you don't think that, I guess that there are no consequences. And then 14% of you said that it is worth it, but you need some guidance. So that's what we're here for. Okay. So as I promised before, there are some exceptions or some exemptions from MIPS and MACRA in general, and let's take a look at those. So you can be exempt if you're a first-year Medicare Plan B participant. So if you're just out of med school or out of residency and this is your first year, you can claim an exemption from MACRA or from MIPS in 2017. you will have to participate in 2018. You can be exempt from MIPS if you bill less than $10,000 in Medicare annually and see less than 100 Medicare patients per year. Make a note of this "and" here. It's not either or. It has to be both. Absolutely has to be both. So if you bill less than $10,000 in Medicare but see 101 patients, you're not qualified for an exemption. As I mentioned, MACRA has two tracks. One is the MIPS, which is what we're reviewing right now. The other one is the advanced APMs. If you are part of an advanced APM, you can be excluded from the MIPS portion of MACRA. Okay, non-Medicare participants. So right now, as I mentioned before, this is a Medicare initiative. This is a Medicare program. Non-Medicare participants don't have to do MIPS. However, like expected and mentioned before, is that other payers will soon adopt similar models. Okay, and then you can also claim an exemption from MIPS in 2017 if you're a clinician in a rural health clinic or a federally qualified health center. So let's take a look closer at MIPS. The performance threshold for MIPS will be determined by CMS annually. So there's going to be a mean or a median of MIPS scores from some previous years that CMS selects. So for the first 2 years of the incentive, because MIPS is just starting, what will happen is CMS will base these means and these threshold values of where they want you to be at from your meaningful use and PQRS and value-based modifier scores. So at this point, we'd like to offer another poll question.
So the question is, have you participated in meaningful use and PQRS in the past? We'll give you guys a few seconds to vote. So the results show that 44% of you did participate in both. That's great because you have a head start in understanding all of the performance categories in MIPS. 22% of you have done meaningful use only. Nobody did just PQRS only, and 33% of you didn't do either meaningful use or PQRS. So it's not too late to do meaningful use or PQRS for this year. If you don't have a certified EHR or one of the huge requirements for meaningful use this year, which is a patient portal, we can guide you in the direction of trying to apply for a hardship exemption. As far as PQRS, you can still try to report through either your EHR, or if you don't have an EHR, there are registries out there that are helping providers report. So you can talk to us about one of those. The penalties this year are pretty great. For meaningful use, it's a 3% deduction or penalty in your 2018 Medicare Part B claims, and for PQRS, it's 4%. So that's a combination of 7% total. So I would highly suggest that you look into any possible way of reporting this year or trying to fill out that hardship exemption.
And let's take a closer look at the MIPS performance categories. So the score that you will want to achieve is your total composite performance score here. It's out of 100 points. So this is your total composite score. It's, like I mentioned, out of 100 points. And in order to get this high score, you will need to do well in the 4 different MIPS performance categories. So that is your number 1, quality, your number 2, meaningful use or ACI, your number 3, resource use, and your number 4, CPAA. Your performance in each of these categories will add up to that total composite score of up to 100 points. So let's take a look at the quality category first. That's this one. This is very similar to PQRS. So for those of you who have participated in PQRS before and are familiar with the previous 9 measure requirements across the 3 domains, in the MIPS quality category, there are only 8 measures and no domain requirements. You select 6 measures on your own and report to these, and you can record these in your EHR and then extract the reports from the EHR and submit, or if you have the registry that you want to continue working with, you can do so through a registry. One of these 6 performance criteria that you select has to be a cross-cutting measure. So that means that it applies to a large population. It could be something like a smoking cessation counseling or recording recording medications for all of your patients. Those are your cross-cutting measures. And then one of the other 6 that you select has to be an outcome measure. And so for an outcome measure, for example, that could be your hemoglobin A1C for diabetic patients. CMS will collect 2 additional population measures on top of your 6 from your claims data. So if you're reporting via registry, a physician must report on 90% of all, not just the Medicare patients. If you're reporting via claims, you must report on 80% of your Medicare Part B patients. So bonus points are possible for each additional measure reported. So if you report on more than 8, or you can get bonus points for that category. Okay. The next category is your ACI, and this is practically the same thing as what meaningful use was, with a couple of adjustments. The important thing to note here is that CMS drops the all or nothing approach. So that's pretty much your biggest change from what meaningful use was. If you did meaningful use before, you're familiar that if you failed one measure previously, you failed the entire meaningful use. There were some exemptions that you could take, but if you, for example, didn't get access to the patient portal, or if you didn't prescribe enough medications, you ended up failing the measure. In MACRA, you get credit for every non-zero reported denominator and numerator, so you could still technically be at a very low percentage for patient access to the portal and still pass the MIPS portion of MACRA, but it's a sliding scale, because what they do is they compare you to other providers. So while you're still passing MIPS, your penalty or your reward is still going to depend on how other providers do. So it's no longer just making sure that you meet the threshold, it's now also making sure that you're way above the threshold, because you're going to be compared to this pool of other providers. So that's pretty much your biggest change for meaningful use, because at this point, the physician next door that gets a higher percentage could be getting your incentive payment. So that's your meaningful use. The next category that we're going to look at is your resource use. And so resource use are pretty much cost-associated measures that CMS will extract directly from your claims. So this replaces your value-based modifier if you participated in that before. They will compare your costs with the target Medicare expenditures that, again, they will determine what the target is, and they will score you based on that outcome. So they'll look, for example, at the type of the measure, the number of cases that you reported for these performance, and the related expenditures. And so they'll have a threshold expenditure determined, and if you, for example, score above or below that, that's what your reward or penalty will depend on. So if, for example, your expense for a specific measure for all your cases was $15,000, but the threshold that Medicare established was 13, then you will receive a lower score for this category, which will end up adding to a lower composite performance score. And then the last measure that we're going to look at, or the last performance category, is your CPAA. It stands for Clinical Practice Improvement Activities category. Physicians will need to report on medium and high weight of the proposed list of activities. So Medicare will have a list, or already has a list of activities that they propose for this category. The activity categories, just to kind of name a few, include things like expanded practice access, population management, beneficiary management, patient safety, practice assessment, integrated behavioral and mental health, and so on. There are a few of them. So, for example, if taking a look at the expanded practice access, that includes activities such as scheduling same-day appointments for urgent care needs and after-hour appointments for urgent care patients. So if someone calls and has an urgent need, you have to be accessible to place them in on your schedule at some point during the day, and also have after hours for them. Population management includes things like health conditions and providing timely intervention and participating in a qualified data registry. Care coordination category includes measures such as timely communication of test results, timely exchange of clinical information with patients and other providers, use of remote monitoring or use of telehealth, And then category like beneficiary engagement involves setting up care plans for complex patients and so on. So if you kind of look at your practice, a lot of you are already doing a lot of these things. It's just a matter of making sure that you place them somewhere in your EHR that can pick up and report these measures. Because if you're doing them and you're free texting them, or you're doing that but you don't have a system set up where you track things like that in your EHR, you have no way on reporting on them. And so that's where they're going to kind of be able to apply penalties. So we're going to offer our fourth poll question.
And the question is, do you know how to run the clinical quality report? All right, looks like we got the majority of our votes in, so sharing the results. So it looks like 0% of you don't know what that is, so that's great. Everybody at least has an idea of what the clinical quality report is. It's one of the most important reports that you can run, because from this report you'll be able to view the quality that your provider is administering to your patients. Now, in many cases, when reviewing some of these measures, some of you have questions about how numbers get picked up for some of these measures, or you feel as though you should have a higher number for some of these measures. So that's what we are here for, to help you analyze these reports and explain to you how numbers get picked up and figure out why patients aren't getting picked up. But having that basic knowledge of being able to run the report is extremely important. So we're here to hold your hand and guide you through the analyzation, but we want to make you independent in the sense that you're capable of running these reports and tracking your own progress. If you're on one of our PQRS or meaningful use plans, then we do that for you periodically. But if you can do that on your own, then that's even better, because two heads are better than one. So if you can track your progress and we can track your progress, you're on a good road to achieving the highest quality of care possible.
Okay, thank you, Justina. Okay, so let's look a little bit at the advanced APM track, which is your other option or your other way to meet meaningful use. Okay, so as I mentioned before, advanced APMs often include additional payers that participate in Medicare, so it could be things like all of your HMO plans. They aren't offered to every provider. The only models that are available right now are Comprehensive ESRD Care Model, Comprehensive Primary Care Plus Initiative, Medicare Shared Savings Program. If you are part of that right now, please make note that Track 1 does not qualify. You have to be in either Track 2 or Track 3. Then your next generation ACO model and your oncology care model. The important thing to note is that if you didn't know about these before, and this is the first time that you're hearing about it, a lot of the timelines for applications already passed. So if you didn't apply for comprehensive primary care, it's too late now. Same thing for the next generation ACO model. I don't know if they're going to open the applications back up for the 2018 participation. But for the 2017, the comprehensive primary care and the next gen ACO are already closed. If they will create a lot more APMs going forward, so these aren't the only ones that you're going to be limited through for the remainder of MACRA. So they will open these up. I encourage that you stay on top of these and sign up for CMS newsletters, and every now plug into Google, advanced APMs qualifying for MACRA, and do your research on it, because they will open these up. The difference between something like an advanced APM and the MIPS portion of MACRA, the other way of meeting MACRA, is that advanced APMs, in these, oftentimes your rewards are a loss. So in MIPS track, you're compared to a slew of other providers. You have these PQRS, meaningful use, value-based modifier measures that now get all combined into one, and or what the incentive or penalty is that you get is compared to how someone else in your region does. And if someone else does exceptionally well and you're kind of in the middle, you either get a negative or a positive or maybe no adjustment at all. And so it kind of makes it harder. With an advanced APM, you're not compared to all of these other providers. What they'll do is they'll typically attribute or impanel patients to your practice, and they'll give you a certain amount of money to take care of these patients, and then they'll also give you an incentive as a lump sum on top of it. And so they'll ask you to submit reports maybe on a quarterly or an annual basis, depending on the kind of advanced APM that you're in, and they'll assess whether or not you're meeting the quality of these or the quality of care that they're expecting you to have for having given that incentive payment to you. And if you don't meet that quality, they'll take that incentive payment back. But at the end of the day, you're not really losing anything out of pocket. I mean, it depends on an advanced APM. There are exceptions to this, but for the most part, your potential reward is your potential loss. So advanced APMs are a slightly better track to go for those practices that have already mastered PQRS and meaningful use and already know how to input all that data and report on it. Okay, so is it too late if I don't have an EHR? Oftentimes the providers will ask this question. MACRA does start in 2017. An 3 months left is an intimidating amount of time. It's not too late. If that's something that you're considering and you are an eligible clinician for participating in MACRA and you do bill Medicare Part B above $10,000 of it, then you would certainly want to make sure that you explore this as soon as possible and you get an EHR as soon as possible. We can still implement, or you can still implement and train on it and start inputting everything into the EHR by the start of January 2017.
Okay, so now it's time for our final poll question, which is someone in charge of quality program requirements and research in your office? Okay, I'm going to close the poll here and share the results. So 22% of you have an office manager in charge. Not surprisingly, the doctor is not in charge in any of your offices. 11% of you are not sure. 22% of you say no one is in charge, and 44%, the majority, say that the whole staff works together. So starting with that one, it's great that you have everyone working together, and it's really important that everyone has a flow and understands who is responsible for meeting which requirements. But we do urge you to choose one person to be the leader for these programs and kind of do some preliminary research, definitely to run those reports periodically. You need to have someone held accountable, because usually in situations where you think the whole staff is working together, no one is claiming that leadership and responsibility, and in the end you may think that Connie at the front desk is running the reports, but it turns out that at the end of the year, when it comes to reporting, nobody was actually checking the progress and you failed one of the measures. So we think that it's really important that you have one person in charge and managing it. For those of you that have no one in charge, that's not good either. Talk amongst yourselves and with the doctor and see who can be in charge of this. Now, MicroWise does offer assistance for reporting on meaningful use PQRS, and we will offer it on MACRA, of course. So if your office is too small and you feel really overwhelmed, you've never done any of these programs and you don't have any information, then talk with us and maybe we can have we can work with you and have someone on the EHR team take charge of that and kind of claim responsibility as far as running reports and following up with you on progress. It'll still be your responsibility to enter the data in the EHR, but we'll do our best to set up your progress notes and train you on where the information needs to be entered. Obviously, we'll do research as well, and you'll be one of the first ones to find out about any new information regarding the programs. It's great that we can see that 22% of you have an office manager in charge. We would say stick with that so that you have going forward you have someone who is running the reports and will claim responsibility for MACRA.
Okay, and just to add to that, what I do encourage is, there's an overwhelming amount of information out there, but attend these webinars. If you have a question, ask. Don't leave things unknown. Even if you email us, call us 20 times a day, just make sure that you understand this fully, because the repercussions of not understanding and overlooking something or letting things fall through the cracks are a lot larger than just taking the time to kind of look into it and, you know MACRA like the back of your hand.
Good advice.
Okay, so at this point, we're going to open up the floor for Q&A. I'm going to unmute everyone. We have a couple of questions to start out with, so we'll start with those.
Going forward, we're going to have, this is just the first webinar in a series. So on the 29th in a week, we're going to have a webinar that gets into MIPs more specifically and the performance objectives in it. That one will actually be in the morning. We've gotten some feedback that afternoon webinars don't work so great, so we're going to switch it up and do that one in the morning. If that doesn't work for you, no problem. We'll have a recording just as we will. Thank you. Thank you to all of you for joining, taking the time out of your day to learn about this. It's really important. We can't stress it enough that you're prepared for this. Many practices don't realize how important it is, and they're going to wind up going out of business. So the fact that you're here today with us shows that you care, and we appreciate that. And thank you, Vida, for all of your super valuable information.
Thank you.
Thank you, girls.
Thank you.